Thank you, sir, for the lovely introduction. And it's my pleasure to be here in the platform, and it's a very nice opportunity as well. So, I think we have spoken about a lot of neurological aspects earlier, but this is completely a different ball game because when you see dysmorphology as in the perspective of pediatric practice, so this may not constitute a major chunk of your OPD or IPD, but still this is not a rare entity that everybody should know, and most of the genetic disorders are actually misdiagnosed or missed. So we'll try to understand the basic concepts of genetics and identifying dysmorphology in this particular session. And it's very difficult to cover all the aspects of dysmorphology and all the aspects of genetics pertaining to pediatric practice in one lecture. But this is definitely going to be a prologue to the upcoming workshop that Dr. Nitin will soon discuss. We'll have many sessions following by in the next month or so. So, just are the slides moving? One second. Can you hear me, sir?
Yes, I can.
My slides are not moving. One second. I'll share again. Can you see my slides now?
Yes, they are moving as well.
Yeah, okay. So in this session, we'll be discussing the first part of our series, that is introduction to the genetics and also the dysmorphism morphology. And in the coming lectures, we'll be looking into the core clinical aspects of diagnosing a genetic disorder, that is going to be dysmorphism in a detailed perspective. Followed by that, a very often missed aspect by pediatric practitioners, that is use of ancillary tests in diagnosing genetic disorders. Ancillary, I mean tests other than testing, and also choosing the appropriate genetic test. This is going to be a different lecture altogether, and this is going to be in 2 or 3 sessions. Again, it's going to be a huge discussion and a special focus on a special lecture that will be on treatable genetic disorders, which cannot be missed. And lastly, prenatal genetics. So, starting today, we'll be looking at the importance of diagnosing genetic disorder and dysmorphology, the very basics of dysmorphism, and few definitions. And I'll introduce you the concept of deep phenotyping and reverse phenotyping, and few basic definitions in the field of dysmorphism, and a few case-based scenarios to understand these concepts. So this is a picture from 19th century. This is a painting which represents Angelman syndrome. So the dysmorphism concept has a very huge history, but I'll just cut it down. So this is again a statement given by a great scientist who actually worked on dysmorphism. So he said that there's something of the 19th century about the science of dysmorphism and the idea that medical conditions such as Downs and Angelman syndrome, whose main consequences and the neurological consequences imprint themselves in the body shape in ways reliable enough to be used for diagnosis. It sounds quite similarly as phrenology and physiognomy. So this was a concept which was before dysmorphism. So the science, this science came from Germany, wherein you try to identify the aspects, the functional aspects, and also the personality of a human being based on his face. So, for example, in this picture, which shows that based on the structure of the forehead, structure of the nose, and also the pointiness of the nose, apparently uh, matched the personality of that person. So if you see on the right, this person actually was labeled an unreliable husband when compared to the left one, a genuine husband. So this concept of identifying the physical traits and matching them to the personality is called physiognomy, and especially the cranial features is called phrenology. And this was obviously discredited and rejected. And after that, then came the concept of dysmorphology, that is identifying the physical traits of a disease that can be the only feature of that particular disease. So the oldest genetic disorders which were described were Down syndrome and Angelman syndrome. So this was a painting of an Angelman syndrome patient who had a very happy demeanor. So that was a representation. So the history goes a long way, and we'll just discuss that as well. So, if you see the definition of dysmorphology is a discipline of clinical genetics which deals with study of abnormal patterns of human growth. So, we often think that no, the word dysmorphism only pertains to facial dysmorphism, which is actually not correct, because it's the entire body. So, the abnormal patterns of human growth, and with the recognition of study of congenital human structural anomalies and patterns of birth defects. So, the term dysmorphic itself can be used for individuals who have physical features which are not usually found in other individuals with similar age and ethnic background. For example, a 7-year-old boy comes to you with a very old man appearance, so that is a diagnostic feature of cocaine's disease. But the same appearance, if it happens in the 70-year-old, it obviously is normal. So it has to be age matched, and also we have to compare to the ethnic background. So I don't have to explain the ethnic background because there are a lot of genetics disorders which actually need to be understood in the background of the ethnicity. For example, Down syndrome itself. So if you have a similar faces in a Mongoloid community, that can be pretty much normal. So a lot of pediatricians think that what is the big deal of identifying a genetic disorder in your OPD? What, because most of them actually think that no, there's nothing which needs to be done. Most of the genetic disorders are not treatable, and but what's the point, talking about these genetic disorders? But at the end of the lecture, I think you'll understand it's actually a big deal identifying a genetic disorder. So quickly about the history. So 17th, 18th centuries, and nothing much about dysmorphism. All the studies before that were discredited, and the main science behind this actually originated in Johns Hopkins. As many good stories in science and medicine actually originated from Johns Hopkins, and even this has actually come up from Johns Hopkins only. So the he is primarily a physician who worked especially on abnormally developing children. He's David Smith. So his work has extensively given credits to human malformations and congenital malformations. He was the one who actually introduced the term dysmorphology, and back then it was like quite similar to syndromology. Identifying syndromes and genetic conditions was equated to dysmorphology, but there are they're not exactly the same. So, what is the main issue? So, for example, in our pediatric practice, as well as a lot of physicians even have genetic disorders. If you see the time the patient comes to you, the symptoms appear, and by the time the patients visit the GP, there is already a lot of delay because a lot of genetic disorders do not have acute presentation. So they come to GP maybe after a few months, few weeks. It depends on the patient's parents. And once they come to the GP, that is the primary GP is going to be pediatrician in our setting, and the pediatrician will sometimes identify few signs and sometimes can be missed. It can no It's understandable that no, a lot of busy practice, this dysmorphism can obviously be missed. So you won't have a diagnosis in the first visit, and maybe the pediatrician has identified few features and has ordered blood tests, and this then he decides that no, this is not his arena. Then he actually uh, refers to a specialist, maybe a neurologist or a geneticist directly. So the specialist will order for more tests like MRI, skeletal survey, metabolic workup, etc. And the tests come back with the comparison. You try to match the test with the clinical picture of that patient, and you obviously have to go back to the literature and search about this particular condition. And then again, sometimes from the pediatric neurologist, the case gets referred to a genetic expert, a geneticist or a clinical geneticist, and here you get a more number of tests being ordered, that is genetic testing. And then finally you get a test which is going to be uh, the final answer for it, and final diagnosis would be obtained then. So this the whole process is going to sometimes take a huge burden to the family and a huge toll to the entire patient as well as the family. So these are some of the statistics. If you see the European data portal, the average age of delay in the diagnosis of rare diseases is 7 years. So this is a huge burden to the family, patient, as well as the community, because it's going to have a financial toll as well. This is the European data, and if you see in the United States, the average delay or lag, the latent period is almost 4.8 years. So this has to come down because uh, specialists and neurologists and geneticists are not available at every community level. So the first approach, the first need is to pick up pediatricians and train them to find rare diseases. That is going to be the most useful technique here. Next thing, you know that the recognition of genetic disorders is increasing day by day. And back then, if you see 2015, when compared to 2015 to 2024, the usage of genetic testing has gone up very significantly, and so is the genetic testing global market. If you see lots of billion dollars being spent and invested in the genetic testing. So the era has started from karyotyping back in 1975, and now we are in the era of whole genome sequencing, and whole exome sequencing has actually uh, has reigned in the last 3 years, and now we are in the era of whole genome sequencing, which is easily and pretty much affordable now. So, what are the benefits of diagnosing a genetic disorder beyond treatment? So, I'll be talking about treatable genetic conditions in the next lecture. But beyond treatment, for example, inborn errors of metabolism are one of the top priorities in diagnosing, because you'll have immediate effect on the management. If you have an MSUD diagnosed on day one, so you obviously stop the feeds, and potentially you treat the disease or cure the disease, because acidosis won't happen. So inborn errors is a whole different ball game, because in inborn errors of metabolism, genetic diagnosis is extremely important in management and also saving a life. But let's not talk about the treatment perspective here. Beyond treatment, what are the other aspects of diagnosing a genetic disease? First thing is the end of diagnostic odyssey. So diagnostic odyssey is a journey where the patient and the clinician goes through from the point of contact with the first symptom till you get the final diagnosis. So this diagnostic odyssey is going to be a very extremely long in a genetic disorder or a rare disorder, due to many reasons. Because the first thing is the decreased the decreased understanding of this entity by the parents, decreased understanding by the primary physicians, and also the availability of tests are not as easily available as other tests you have. And also finances also play here, because few genetic tests are going to be expensive. So let's try to understand that this particularly affects the families in all aspects. In the financial aspect, also the mental trauma that the family or the mother goes through. You have a child who is undiagnosed for so many years. And next is to when you diagnose a genetic disorder, though the treatment is not there, but you'll obviously know the prognosis. For example, you have Noonan's syndrome. You don't have specific gene therapy in Noonan syndrome, but you know that you might expect cardiac complications, you might expect renal complications. You screen for them and you be very vigilant, and you have annual screens, and you prevent potential conditions. So that is one example. We'll look at more examples. I mean, apart from treatment, we can also prognosticate the condition. And more you find out the genetic origin of the diseases, then only you'll find targeted approaches to treat. For example, SMA back then in 20 late 2000s, there were very few patients with SMA got diagnosed. So leave alone diagnosis, how will you have gene therapy if you don't have diagnosis? So more and more number of patients being diagnosed, then you find out the exact genetic origin of that disease. You'll understand the etiopathogenesis, the exact genetic source, and then probably more pharma companies will pitch in. The funding won't be an issue then. So that's what happened with SMA and Duchenne muscular dystrophy. More cases being diagnosed, more genetic origin, the more clearer pathology being known, then the pharma companies pitch in more and more money. Exactly the same concept for access to research. So more and more clinical research happens when you have a final answer. And informing the family is one important thing. One is with the next pregnancy, if the family is planning for another baby, the genetic diagnosis is going to be extremely important, because you can potentially prevent that in the next pregnancy with prenatal genetic testing. And second thing, and also explain them the accurate recurrent risk. So, and it's a very clear thing. In autosomal recessive you have 25%, with the next pregnancy in autosomal dominant you have 50%. So you can probably tell them, so the family actually plans up how to go about. So these are few of the other aspects, in diagnosing a genetic disorder, and you have a final diagnosis. So I understand that your concern here is you have a practice of 100 patients, OPD sitting outside your room waiting for the whole day. How do you expect a pediatrician to understand and note down the extreme details of dysmorphism, like measuring intercanthal distance, measuring the size of columella, and taking pictures from the side angles, taking pictures from the front, do the anthropometry. So I understand this is not going to be possible. You have more pressing issues like sick patients waiting outside, which need more immediate management. So that's the typical pediatrician in India. I understand that that is the reason why uh, dysmorphism cannot be, picked up in the first instance. That is very understandable. So all that I'm saying is geneticist has a lot of time. We don't have that many patients. If you don't have time, all I'm saying, we don't know more than you, but we have more time than you, definitely. So we look at the patient in more detailed aspects, try to identify each and every physical aspect and try to formulate a hypothesis. So that's what we can do with, because we look for more aspects than a general pediatrician does on general physical examination. So we are trained to do that. So obviously we'll find out more and more problems pertaining to a genetic disorder. But as a pediatrician, at least you must understand and pick up a probable genetic disorder, and timely referral to a geneticist or a specialist is going to be extremely important. So these are some of the statements given by the ACMG few experts. So pediatrician, this is not me talking. It's actually one of the expert talking from the ACMG. The pediatrician is not expected to recognize and diagnose all possible genetic syndromes because it's not possible. That is the reason we have subspecialties. Everybody cannot know everything. But however, no, he must identify patients requiring specific investigation and start diagnostic workup to guarantee that the patient will receive a timely diagnosis or a timely referral. So this is the example I already gave you about Noonan syndrome. Another example is that identifying few genetic syndromes will actually, help in potentially identifying a very dangerous conditions. For example, few genetic syndromes have precancerous states, that is, risk of cancer is very high. So, for example, Costello, Rasopathy, so Bloom syndrome, cocaine syndrome. So identifying these will actually give the patient a good prognosis, because we can annually screen or we can identify a tumor very early on. So next thing is that, see, the detailed examination of the genetic. The first look, everybody is able to recognize a face. For example, you can't miss a face who is like coarse faces. Like if you see mucopolysaccharidosis, MPS, or mucolipidosis, you have a very distinct coarse faces that nobody should miss. But for example, uh, if you identify a face which is not very distinctively dysmorphic, but it has some dysmorphic features, you can mention that and refer to a specialist. So that is you can do at a primary physician level. So the problem here on the left side, if you see the first picture, so this one, so this is a family of achondroplasia. So achondroplasia, most of the patients or the diagnosis is often not missed because it's written all over the body. It's nobody can actually miss a case of achondroplasia because the physical traits are very extremely clear and loud. In the second picture, if you see, this is a child with achondroplasia, but even the face is covered and the head is covered. If you see, there's some features of coarseness or some features of achondroplasia already in the flat bridge. So the first picture nobody would miss. The second picture, some people, some pediatricians may miss because in the busy practice it can be a normal facial appearance with some families. So the second picture is a problem. The third problem on the right side, if you see this picture, so this child, if you see on a very broad approach, you may not feel it as dysmorphic because there are a lot of Indian families who have specific facial appearances which are similar to family and also to the parents as well. So this is a child with Noonan syndrome. So on the first look, people can miss it, but if you actually start noticing each and every parameter, low set ears, prominent cupid like upper lip, you have all these features which are very prominently saying that this is actually a child with dysmorphism, like quite similar to Noonan syndrome. So the problem is here when the dysmorphism is not that evident or not that clear or loud enough. So these cases can be missed. So this is when you need to have that suspicion to actually think that there could be a genetic etiology. So coming to the testing, so this was the most asked question. So how do we comment on this particular thing? If you see back then, there's a particular algorithm to diagnose a genetic disorder. Like, so there cannot be a shortcut. There's a reason why the original road is made that way, and the shortcut needs to be taken only when required. So what is happening now, the suspected a genetic disorder, a very mild suspicion, you're not even sure that you have ruled out other required conditions or other associations or other non-genetic conditions. So even the faintest doubt and subtlest doubt, a very trivial uncertainty, you just order the next test is going to be whole exome sequencing. So this is going to be creating a huge problem, because you will not find answers always on whole exome sequencing with minimal information you gave to the geneticist. So the more you explore, the more information you give, the more information you get from the whole exome sequencing. So they often say that if you give garbage to the geneticist, the report is going to be a garbage. So it's something like that. So you need to be extremely careful. And nowadays, if you see the lot of whole exome sequencing being ordered left, right, and center, but I think that needs to be carefully correlated clinically. So that's about the introduction. So I'll introduce you to another important concept of deep phenotyping. Why you need to know this? We often think whatever the cause is, whole exome is going to pick up. So what is the point of wasting another 15 minutes time to actually examine everything and test all of the other conditions and then go for whole exome sequencing? So I get that question. So let's analyze why that is not preferable. So there are a lot of articles which have actually proved that deep phenotyping actually helps to increase the yield of whole exome sequencing rather than sending whole exome sequencing right away with very few information. So let's see this case on the left. So this child was a 16-month old who had global developmental delay and whole exome sequencing was sent. And the whole exome sequencing came back negative, saying that there's no cause identified. So that's when the pediatrician has referred us. So the deep phenotyping was not done. So deep phenotyping is basically looking at all the aspects of the clinical examination. So this child actually was a non-consanguineous marriage with no significant family history, but there was history of IUGR. So I meant to place this case because deep phenotyping actually starts from the antenatal period. Extremely important. All the features are going to be important in deep phenotyping. There was postnatal growth faltering, and the child had relative macrocephaly and also dysmorphic. If you see there's broad forehead and triangular faces, and if you see retrognathia to some extent, and prominent nose. The child also had clinodactyly and developmentally motor more than language. So this child ended up being Russell Silver syndrome because whole exome sequencing is not going to pick up Russell Silver syndrome in most cases because it's a the mechanism is different. You have imprinting disorder. You have to go look for methylation studies, a specific test for that. But if you see the physical aspects actually matched the syndrome, so this is the importance of examining the child with a detailed anthropometry. So the relative macrocephaly, the short stature, the intrauterine growth retardation, all these were the important clues in this particular case. So this is the importance of deep phenotyping. If you don't have much information being given to the geneticist, or if you don't order an appropriate test because the phenotype was not analyzed properly, you are not going to have a final answer. After deep phenotyping, you'll have to know about reverse phenotyping. So this is being done at many institutes now. I understand why this concept has come. Let's just go quickly. For example, there's a child with suspected MPS, mucopolysaccharidosis. So the clinician has suspected it, and then you have a battery of tests. That is, as I said, the deep phenotyping. You have to examine the child detailedly. You have to look for corneal clouding. You may have to send the child for slit lamp examination. You have to get skeletal survey to see the physical aspects of dysostosis multiplex. Examine him. Maybe get an ultrasound abdomen to look for organomegaly. Maybe get 2D echo to look for cardiomyopathy, and also look at the MRI findings of MPS. You can have white matter changes, you have J-shaped cella, etc. And then try to metabolically prove with urine for glycosaminoglycans and then enzyme assay, and then finally get whole exome sequencing. If you see that this is the actual pathway for diagnosing a genetic disorder, right? But if you see in this particular algorithm, you end up spending a lot. Skeletal survey, 2D echo, MRI brain, 10, 15, urine for gag, another $2,000. Enzyme is another 3,000 to $5,000. The whole battery itself takes around $20,000 plus the whole exome sequencing. There's another 10 to 15,000. So the whole financial burden is going to be very extremely high in this particular algorithm. But another alternative for this is you have a suspected patient with MPS. You can directly go for whole exome sequencing. You are very likely to find the answer in this aspect. So what's the point of deep phenotyping in all the patients? So it depends on the case, what you're dealing with. You know that MPS, all the types of MPS are clearly known genetically and also phenotypically. So in that condition, you can actually send a whole exome sequencing directly with a good amount of clinical information given to the geneticist. So it's mention all the physical aspects you're suspecting this particular condition. So if MPS is asked for, all the similar disorders like mucolipidosis, fucosidosis, all the similar disorders will obviously be looked at higher depth, and you will definitely have a diagnosis in most cases. Or sometimes, if you have a whole exome sequencing done and you have two or three variants being reported, which are variants of uncertain significance, you can go back and do these tests again. So that's going to be your reverse phenotyping. So that is also being practiced in a lot of centers now to cut down the financial aspects. So, for example, for this patient, I have identified whole exome sequencing of two or three different variants, one in MPS, one in mucolipidosis, and one in fucosidosis. Then I would go and do an enzyme assay and skeletal survey to particularly narrow down your diagnosis. On reverse phenotyping, you can actually upgrade your the variant as well. If the clinical match is very consistent with the MRI picture, then you can actually reclassify your variant as likely pathogenic. So that can also be done. That is reverse phenotyping. So so that's the example which I was giving. So that is the reason why people are now also considering reverse phenotyping. I wouldn't advise this in all the cases, because the moment patient comes, you do whole exome sequencing, and then the report comes, you start doing extra tests to identify what is a probable match for this physical the genetic report. So that's not actually advisable in all cases. But when you have a clear cut phenotype clinically, we're pretty sure of what you're seeing, then maybe you can directly go for whole exome sequencing. So on the right side, if you see, this is the new algorithm. The new algorithm still does not skip a careful clinical examination and history. So if you have a suspected genetic disorder, go for genetic testing and analyze the variant in an MDT meeting with a geneticist and also an experts with variant examination. And then you try to match the variant you have identified with the physical traits of that disease, and then the final diagnosis could be explained to the family. So this is called reverse phenotyping. That can also be done in few conditions, but very carefully. So that is the two concepts I wanted to introduce. That is deep phenotyping and reverse phenotyping. The third important thing you need to know as a pediatrician is human phenotype ontology. Why is this important? When you give a lot of information to the geneticist, it's very important that we use common terms. For example, I had seen a report where the clinical history said that the head circumference less than third centile. So head circumference less than third centile is not in the human phenotype ontology. So you'll have to write either microcephaly or small head. So then only that gets picked up. So it also depends on the person who actually shares or translates the clinical information to the human phenotype ontology. So you need to pick up few important terms and enter it up in the algorithm when you analyze the raw data of whole exome sequencing. So you need to have a common clinical terminology across the globe, like when you're using particular conditions. For example, clenodactyly, you have telecanthus, you have losset ears, you have other some common simian crease, all that genetic conditions when you have specific clinical handle, they're all recorded in the HPO axis, so that gets picked up. So make sure you use a very validated or a clear terminology when you mention the history to the geneticist. So this is about HPO. So that is when they try to pick up that particular term which you used on HPO, and then they try to match it up with the annotated genes, and then they'll finally come and give you the answer as the report. So quickly going, as I said, the deep phenotyping includes the entire history. It's going to be extensive, but you have to start right away from the antenatal, from the IVF conception. How was the conception? Then you have the detailed antenatal period, and then very detailed family history that is going to be including your three generation family pedigree. And also another important aspect of the medical history is going to be involvement of other family members in the extended family who had similar history or cancers or early deaths. All that must be asked very clearly. And then after that, you have a head to toe examination, which includes your phenotype examination with deep understanding of that. And then here you have ancillary tests. That is, for example, you can use an MRI if you're suspecting a genetic leukodystrophy. Use an MRI with MR spectro. If you're suspecting metabolic disorder, use GCMS, TMS to find out. All the routine workup should be done. And also, I'll also discuss about few online supportive tools. It's very understandable that you can't remember all the genetic disorders. So whenever you identify a specific feature, you can obviously go back and look it up online and then try to find out or connect the dots to understand the genetic disorder. So we'll also discuss about a few supportive tools which are available online, that is easily accessible to any pediatrician in the clinics. So before that, I'll also introduce to the new concept. This is a brand new concept of last couple of years, maybe. You see a lot of genetic disorders which have common pathways. They have different single gene origin, but in the downstream of that gene effect, all that genes have some common pathway. So if you unite that diseases in one common pathway, they'll have a lot of similar clinical features. So that is when the concept of the disease or the gene or the whatever protein which is there, followed by the pathy concept came. For example, we all know Cornelia de Lange, a very common genetic syndrome with a very characteristic facial appearance of synapse. And the if you see the picture in the left, the center one is going to be the typical feature of Cornelia de Lange. We have synapse and also long philtrum and subtle coarsening of faces. So this is the Cornelia de Lange syndrome. But there are other genes which are in the common pathway, which can also have similar or a very very almost similar like features, but with few variations. So these are the, for example, this is the spectrum of chromatinopathies. So this includes various genes, which include even Kabuki syndrome, Rubinstein-Tybee syndrome, CHARGE, and other complex disorders. So identifying the group of family is also important rather than finding out the exact. It is clinically sometimes very difficult to identify the exact syndrome, or maybe you can just find out, this spectrum. Even if you are able to identify, that is good enough for the geneticist to specifically look at high depth in that particular genes. That is one example. The second example is a very common entity, that is rasopathy. We know that, we know the common conditions of rasopathy, that is neurofibromatosis, Noonan syndrome. They all have a common pathway, so they are rasopathy. In this particular condition, you also have leopard syndrome, that is multiple lent genes, and craniofacial syndrome, and other NS like neurofibromatosis like syndromes. They all have a common pathway that is depicted in the clinical features also. Most of them have capillary macules. Costello has coarse facies. Most of them have cancer predisposition. They also have all this important stuff you have to remember along with. So when you read it in one group, that is going to be extremely important, and identifying also is very important and easy as well when you group it up. I was talking about the online tools, right? So this is one online tool which is called ACMG Act Sheet. For example, you identify disorder and then you know what exactly to do after that. For example, if you identify metabolic disorder, you need to do more testing, more prognosis. For example, biotinase deficiency. Next, you need to do the enzyme level. Then you have to consult the parents. You have to do an MRI. So for that particular genetic condition, you have act sheets. Need to know what exactly needs to be done after that. So these are the standard diseases mentioned in the ACMG sheets. Another controversial topic. This is the app which has come. Play Store. You see it very commonly. That is, a lot of people started using this. This is called Face to Gene app. So this is an app wherein you click the picture of the patient with suspected dysmorphism and you upload it onto this app. So automatically with AI, it is going to pick up all the information from the database of that particular app, and it will give you the probable diagnosis. So this you have to take it with a pinch of salt, because when it first came, I tried putting my own picture. It showed Kabuki syndrome. I was mentally traumatized after that. So you need to be very careful when you actually upload and interpret it with a clinical touch to it, not blindly follow it. But in many conditions, it can still help. And another important thing is like I'll discuss about OMM. It's going to be very extremely important as pediatricians and clinical practitioners. On the left, if you see, there are a lot of risk calculators. For example, this is one of the uh, PTIN is one of the pre-cancerous conditions. So you have risk calculators like Cleveland Clinic PTIN risk calculator, which is easily available online. So you put the patient's gender, put the phenotype, and you probably they'll give the risk for the PTIN being the possibility. And coming to OMIM is one of the most useful tools. Like you put the particular phenotype or the clinical feature in the search with that probable combinations. For example, a child has low set ears and also clinodactyly and also has a heart anomaly. You put them all together, it will show you the probabilities of all three unifying symptoms with one explanation. So this is very often used in our clinical practice. Finally, let's discuss the basic definitions and terminologies in dysmorphology. So, to introduce, these are not a very tough to understand, but to come into the core dysmorphic features with face in depth will be discussed in the next lecture. But you need to understand what are the types of abnormalities or anomalies you see. Broadly, they are divided into major anomaly and minor anomaly. So, major anomaly are like a very significant impact to the baby as well as the functioning of the obviously the functioning of that particular organ. For example, neural tooth defect is a very major anomaly. So so that is the example for major anomaly, but you have also minor anomalies wherein they don't affect. So most major anomalies needs correction, or they're cosmetically very badly affecting, or also they affect the functionality or survival of the baby itself. On the other hand, minor anomalies do not interfere with the life existence. They are not life threatening, and they don't usually need a very complex surgery. They may be sometimes cosmetic. So in the minor anomaly, you have the prevalence of that particular thing is less than 4% in the general population. So it goes very close with another other entity called common variant. For example, uh, you must have heard about bifid rib. Uh, if you get X-rays of children, sometimes you see the fourth rib being bifurcated. So that's a common variant. You see very often you see 2D echo reports saying that the origin of the left carotid artery is not as usual. Right carotid, the arching pattern or the branching pattern of the arch of aorta can have various variants. And also neurologically, if you see the left transverse sinus sometimes can show hypoplasia. Hypoplastic transverse sinus is also a common variant. If you see, these are some of the variants wherein they do not affect the physical appearance of the child, also functionality of the baby. So that's how you differentiate between minor anomaly versus common variant, the prevalence of that in the general population. So on the other side, if you divide the congenital anomalies into isolated and multiple, so remember, multiple congenital anomalies not always necessarily mean that's a syndrome. That can be an association. So, for example, bacterial malformation or charge malformation. So these sometimes do not have a unifying genetic etiology. So chasing them with genome sequencing, whole exome sequencing sometimes won't be useful. But when you have a multiple anomalies, which probably can be explained by a unifying genetic origin, then it's going to be worth chasing. For example, chromosomal disorders, a lot of chromosomal disorders can have multiple organs being affected. Sometimes single gene disorder, for example, tuberous sclerosis, one single gene, multiple organs are affected. Neurofibromatosis, for example. And you need to know that multiple conditions can be caused by single gene, multiple anomalies can be caused by one chromosome, but you also need to know other aspects that non-genetic conditions can also cause multiple anomalies, like fetal alcohol syndrome, like fetal exposure to CMV, cytomegalovirus, exposure to viruses, drugs, valproate. All of them can cause multiple anomalies. So multiple anomalies does not always mean a genetic origin. So you need to look at that as well. So that is when your antenatal history comes very useful. When you compare to isolated congenital anomalies, we'll discuss them. There are three types: that is malformation, deformation, and disruption. We'll understand these three processes in detail. When I explain, try to understand what is malformation, it's a primary intrinsic developmental defect which usually has a genetic origin, environmental origin, or a multifactorial cause. For example, neural tube defects is a very classical example of a malformation, or a CCAM, that is congenital cystic malformation of the lung. So it can have genetic origin, For example, neural tube defects can be seen in particular genetic mutations. Environmentals, exactly when you have folate deficiency, you can have NTD, and it can be multifactorial as well. So it depends. The recurrence risk depends on what is the exact cause. But usually malformation occur in the first trimester, that is during the period of organogenesis. So the typical example would be a neural tube defect, which can be either genetic or environmental. So that is malformation. Second concept is deformation. Deformation is a normally developed structure, but the distortion or the deformation has caused by mechanical forces. So the typical example of this is, clubfoot or torticollis, wherein, for example, oligohydramnios can cause clubfoot. We can have other malformations which can cause clubfoot. This is not necessarily a genetic condition. The third concept is the disruption. Disruption is like breakdown of an intrinsically normally developing tissue or which is already developed due to some disruptive event which has happened, which can be mechanical, vascular, or infectious. Well, the very typical example is amniotic band sequence, like amniotic band surrounding one part of the hand, basically that cut downs the vascular supply to the distal part of uh, uh, the particular limb. So the primarily it's mechanical, which caused the vascular effect of it, which caused the deformity. So this is not primarily a genetic disorder. So you need to understand this, because if you start chasing them, you'll find nothing on genetics. You'll just waste money. So this is a typical example of amniotic band sequence. So these are the three major concepts I need you to understand: disruption, deformation, and malformation. So in the coming lectures, we'll also discuss about the other aspects of genetics, like the core clinical aspects, which include each body part, and you need to identify the exact genetic, the dysmorphic feature. For example, the one full lecture is going to be on face, the facial dysmorphism, upper half, middle half, and lower half, identifying different syndromes based on the face. That is going to be the biggest lecture. And also the other aspects of the physical, like clinodactyly, acromelia, and different aspects of the body derangement, anthropometry. And after that, you'll have ancillary tests. That is, we often forget about ancillary tests like enzyme assays, metabolic workup, neuroimaging, MR spectros. They aid in deep phenotyping, and then a few more lectures which include genetic testing, which one to order, and also a few treatable genetic causes, and finally prenatal genetics. I think I'm done for the lecture. Thank you. I think
Thank
I'll
you,
take up
doctor.
questions.